We are live now. Thank you so much for joining me on this Menopause Mastermind series. Mike McClung, you are over there in Seattle, and I'm very sorry to hear that you've woken up with a case of laryngitis.
Right.
I will try not to talk to you too much, but today we are talking about bone health. But let me give you a quick introduction here. By background, you're an endocrinologist. You're on the board of the International Osteoporosis Foundation. You've been a member of the WHO Task Force on Fracture Risk Assessment, and also contributed to the implementation of the assessment tools that we use. Widely published, a winner of a Golden Femur Award, no less. So there's probably very few people on this earth who know more about bones than you. And you've been calling for, on an International Menopause Society talk that I watched, which was fascinating, pretty much a radical change in the way we look at osteoporosis and aging in women. So before we get to what you're really calling for, I'll get you to come back to sort of just explaining some of the basics about bones, because they're quite complex structures. So tell us, basically, we have the hard outside, we've got the sort of spongy trabecular stuff in the middle. What do they do and why are they important?
Sure. And before I answer that, let me add just a couple more things. I'm actually in Oregon, not Seattle.
Oh, sorry, I don't know why I keep thinking that. Oregon.
You're right. So I've been to the Oregon Osteoporosis Center in Portland for many years. And in addition to serving on the IOF board for many years, I was on the board of the North American Menopause Society. So being involved in menopause and thinking about management of bone health around the menopause has been a thing I've been involved in for a long time. So osteoporosis is a situation where women begin losing bone just before menopause. And as we'll talk about, there is a phase of quite rapid bone loss that happens for a few years. And then bone loss continues for the remainder of a woman's life. And that bone loss results not only in low bone density, which we all know about and associate with osteoporosis, but it also destroys or deforms the architecture and the structure of the bone. And it's that architectural destruction that actually makes a bone be weak as people age and predisposes them to fracture. And that's the consequence of osteoporosis. And fractures typically begin happening in the late 50s or early 60s, maybe with a forearm fracture. Later, vertebral fractures or spine fractures happen. And then the most serious of all the fractures, because it happens in older age, are hip fractures, which can have devastating consequences, of course, for the patient.
Now, this is an interesting thing, because we often think of hip fractures and osteoporosis. We sort of think of it like, oh, that's the little old lady, that's the 85-year-old down the road. But there was quite an interesting study that came out of Australia a little while back that actually, I think, showed from memory, and I might be wrong, but around about 68% or so of the fractures happened in women under the age of 65. So this is much earlier than we would normally expect this to happen.
And not only that, most of the fractures happen in women who don't yet have osteoporosis by the standard bone density criteria. And so in a big study in the United States done a few years ago, about 15% of women younger than age 60 already had osteoporosis by bone density testing. So the whole idea that osteoporosis is a problem that concerns and affects older women is simply wrong.
Yeah, and we have to really start thinking about it quite differently, don't we? So you've called for this sort of lifelong plan, but before we get to that, a couple of the things that for people to get a DEXA scan here in the UK, at least, you basically have to have either be over 65 or over 50 and have a number of
Risk factors.
Right. If you don't have those, then it's very, very difficult. And often the advice is, well, go online, do one of these FRAX assessments calculations, and take that into your GP, and then get them to write you a referral. What exactly does the FRAX calculator look at? And is that actually an accurate way of predicting somebody's risk of osteoporosis?
No, that's a good and important question. So FRAX was designed to identify individuals who at the moment were at high risk of fracture. And it's those people that we want to identify so that osteoporosis treatment can be administered to protect them from future fracture. But FRAX is not useful in identifying women who are at risk for developing osteoporosis. So a woman, for example, who is 2 years after menopause, who's 52 or 3 years old, who is in the process of losing bone rapidly, may be at very high risk for developing osteoporosis in the next 10 years, but her risk of fracture at the moment is quite low, and FRAX will not identify that. There are other tools. The easiest is called the osteoporosis self-assessment tool that is designed to identify women who don't have low bone density. And it's, again, you can go online and find that. It uses simply age and a person's weight and makes an assessment. Women who are thin and who are older are more likely to have low bone density. And if you have a good number, then it's very unlikely. So that can be a tool used to identify women who might be candidates for bone density. That would be a much better tool than the FRAX tool for that indication.
Yeah, it's an interesting one. Actually, I did that earlier today, and I put in because I'm now at the ripe old age of 61. So I did for what my weight was when I was 50 and what my horrendous weight is now. And at the moment, I'm in a really good state. But back when I was 50, I actually would have been right on the borderline of what I should have been. But nobody mentioned this back then.
Right. So,
So
so in the States here, the indications for bone density testing are, as you pointed out, women over age 65, because age is a risk factor for low bone density, or other risk factors. And one of the risk factors is being thin. So we know that for young women, the strongest predictor of bone density at the moment is what her body weight is. So women in the lowest quartile of weight, and in the U.S., when that was done 10 years ago, the threshold was 127 pounds. The women who were in that lower quartile would be candidates for bone density testing, even at the time of menopause.
But would they get it? I guess that's the thing, because I can imagine here that there would be a lot of people who would go off to their doctor then who've done these types of scores, and they're going to look at them and go, "You're fine. Your risk fracture is quite low." So are we missing a cohort of women?
Well, but this is the point. There's a very big difference between the objectives of osteoporosis treatment, which has been our focus in our field for the last 30 years, where we identify individuals who are at high risk of fracture, give them a drug to reduce their fracture risk. And FRAX was developed to help us identify those patients. The idea of osteoporosis prevention is to identify people who are most likely to develop osteoporosis relatively early in life, and to intervene before they get to be at high fracture risk and to make them not get there. It's way easier and much less expensive to prevent someone from developing osteoporosis than it is to treat or to attempt to correct it once it's developed.
In terms of prevention, we hear an awful lot at the moment of people basically saying, forget about going and having a DEXA scan. You don't need to worry about this. All you've got to do is make sure you're eating right, you've got enough calcium in your diet, you've got your vitamin D, and you're doing your resistance exercise. Are these things enough when you hit that menopause transition period where you lose up to 18% of your bone mass? Are those things sufficient?
Those things are very important, but they are not sufficient. So in weight-bearing exercise is really important in kids while they're growing to improve and optimize their peak bone mass. And it's important in elderly people to be remain physically active that can slow the age-related loss of bone density. But the rapid loss that happens across the menopausal transition is clearly related to estrogen deficiency, and none of the general measures are effective in preventing that from happening. So while it's important to do those things for women who come to menopause with low or low normal bone density, something more should be considered to protect them from developing osteoporosis.
Interesting. Before I get to that, though, so let's be getting to that point where we hit menopause. How important is, I mean, should we actually be talking to women much younger in their 20s and 30s and saying, you really need to be thinking about your bones now and getting them to a peak point, so when they actually get to that transition, their bones are in a good state?
Well, that would be ideal if we could optimize peak bone mass in everybody. The time to do that is actually in childhood and adolescence. So it's while kids are growing that weight loading or like jumping exercises have been shown to accelerate the development of new bone and to increase their bone mass. Once growth stops, and for girls that's in mid-teenage years, then that's it. Our bones don't get longer, we don't get taller, and our bones don't get bigger after that. So once adolescence is over and sexual maturity has happened, then avoiding harmful habits and continuing good habits are important. So avoiding smoking, excessive alcohol intake. For women who have difficulty at puberty, for example, elite athletes whose menarche or onset of periods is delayed, they wind up having lower peak bone mass than normal. And so paying attention to the availability of hormones at the time of menarche is very important. And of course, if people have other medical problems that can adversely affect the skeleton, those need to be attended to during premenopausal years. So all those things are important in preparation for arriving at menopause, where the real action begins in terms of bone loss that ultimately can lead to osteoporosis.
Yeah, absolutely right. So we've got to start working on the poor kids, which is, I guess, given looking at the sedentary lifestyle of people these days, especially young ones, it will be a challenge.
Yeah.
You mentioned estrogen there. So we get to a couple of years before menopause, things start to sort of go down and then continue quite rapidly for 3 to 4 years afterwards, and then start to sort of slowly level out and continue to decline. If we then get to, is there an argument, I guess, then to say, okay, well, I don't want to give people FOMO here, fear of missing out, that more people, even if they don't have the traditional menopause symptoms, should perhaps be on estrogen?
I strongly believe that, and that flies in the face of some of the guidelines in the U.S. The U.S. Preventative Services Task Force in 2022 had their updated position statement about hormone therapy and made the point that it's valuable for symptom management, but should not be used to prevent chronic diseases. It's clear from the Women's Health Initiative and other studies that, it's not proven that estrogen therapy can reduce the risk of heart disease or dementia or other things that people were interested in 20 or 30 years ago. But it is very clear that estrogen or alternatives can prevent the rapid loss of bone density across the menopausal transition and can prevent osteoporosis from happening. Let me emphasize the point you made for those who are listening, that there's a very important study done in the United States called the Study of Women Across the Nation, or the SWAN study, that enrolled more than 3,000 women who were approaching menopause but were not there yet, and then followed them across the menopausal transition. And that study taught us a lot about what happens to bone health across that important and crucial period. And as you mentioned, the relatively rapid decrease in bone density happens a couple of years before the final menstrual period. And the diagnosis of osteoporosis is the diagnosis of menopause is awkward. The definition is a year after the final menstrual period. So you can't make the diagnosis except in hindsight. And by the time you wait until a year after the final menstrual period,
You've
maybe
lost
half,
years.
uh, maybe half of the total amount of bone loss that happens across that transition has already happened.
Mm.
And it's not just a loss of bone density, but the architecture, the structure, and the strength of the skeleton is also rapidly deteriorated during that time. So we have studies, old studies, where we were evaluating drugs for the prevention of osteoporosis, and the women were in the placebo group and had bone biopsies done, and show that over a year's time, uh, some 20% of the bone volume was lost in the women in the placebo group. So, uh, um, and that bone volume was associated with a destruction in architecture. So, the menopausal transition is a special and unique opportunity to intervene and to protect women from that rapid phase of bone loss.
In terms of estrogen then, does it, because, we often hear about, the other types of medications that are used to prevent osteoporosis, such as bisphosphonates.
Right.
In terms of estrogen itself, does it have an advantage in terms of both types of bone?
Yes, the bone loss that happens in early menopause is predominantly from trabecular bone, but cortical bone loss also happens. Both are due to an increase in the activity of osteoclasts, the bone dissolving cells, and estrogen is very effective in inhibiting or blunting that increase in osteoblastic bone resorption. So both cortical and especially trabecular bone is protected by estrogen.
Yeah, because it's an important thing to think about, really, isn't it, in terms of the bigger picture of things. What about progesterone and testosterone? There's a lot of talk, especially at the moment, about testosterone, with people saying you need to be on testosterone because it's going to stop your muscle wasting and it's going to give you your bone strength back. What do we know about both progesterone, progestins,
Yeah,
or testosterone?
progesterone is easy. It has no direct effect on bone. Pure progesterone. There are forms of progestins that have androgen activity that result in a slight additional increase in addition to estrogen. A drug like norethindrone acetate that's often used for menopausal hormone therapy or in oral contraceptives. But pure progestin has no bone effect. Testosterone, interestingly, its effect on bone is mediated by its being converted to estrogen.
Ah, interesting.
Even in men, that's true. So the androgen effect of testosterone does have effect on muscle mass and muscle function. But even in men, at least in older men, it's really hard to demonstrate a benefit of giving testosterone even to testosterone deficient men. And while theoretically that would be useful in managing postmenopausal women, the data to support that simply don't exist.
Right. Yeah, because because you would think logically that, yeah, that's the big androgen, but if it's basically, you need to be well estrogenated.
Right. And and if one is well estrogenized, then the addition of testosterone actually has little, if no, or no additional effect on that.
Right. In terms of people who can't take estrogen for,
Yeah.
the cancer or various other sorts of reasons, what alternatives are available to them then?
Well, at least in the States, there are two other sets of drugs approved for osteoporosis prevention. One is raloxifene, an estrogen agonist antagonist. In the bone, raloxifene has a weak estrogen like effect. It's actually never been studied in women at the time of menopause, uh, in part because we all believe it's probably not effective because it's not potent enough. We know that when women transition from estrogen to raloxifene, it's only partially effective in protecting them from bone loss. So the drugs that are the best options are low doses of bisphosphonates. So alendronate is approved in the U.S. at a dose of 35 milligrams a week, half the treatment dose for prevention. IV zoledronate is approved to be given once every other year for prevention, and the other bisphosphonates are also approved. And so for women that we identify who come to menopause with low bone density, who are at high risk for developing osteoporosis, who can't or won't take estrogen, then being on bisphosphonate therapy to cover the interval of rapid bone loss that happens perhaps up to 5 years beyond menopause would be important. So low dose alendronate for 5 years, 2 doses of zoledronate 2 years apart. Those strategies are very effective in preventing the rapid bone loss that happens.
Yeah. For those, no, I'll stick with this for a minute. I was going to take you back to the estrogen, but I'll come back to the estrogen. In terms of that, then, in terms of your sort of lifelong maintenance plan, are we going to do this, until we're 85, injections every couple of years, or what's your cunning plan for that?
Well, the whole idea of maintenance therapy is a new concept. Even for managing osteoporosis, we focus on our initial treatment where our objective is to maximize an increase in bone density and to reduce fracture risk. But ultimately, even with osteoporosis treatment, everybody comes to a new steady state and is in transitions to what I call maintenance therapy. After the rapid phase of bone loss across menopause, whether women are on estrogen or have taken their 4 or 5 years of bisphosphonate, then maintenance therapy is appropriate. And a recent study from New Zealand published in the New England Journal is a very important one in this regard. They demonstrated that giving 1 dose of zoledronate every 5 years maintained bone density for at least 10 years. And previous studies that we did 20 years ago showed that for maintenance therapy, 2 years of low dose alendronate followed by 3 years off of therapy resulted in maintenance of bone density. So the maintenance approach would be every 5 years course of low dose bisphosphonate, either 1 dose of Zol or 2 years of low dose bisphosphonates followed by 3 years off. And in doing that very safely, without the risk that we associate with continuous use of bisphosphonates, the bone density can be maintained and preserved for the remainder of a person's life.
Oh, that's good, because I was going to ask you about the safety and the tolerance, but you've ticked that box for me. I will give you a moment to recover your voice there. Of coming back to the estrogen, there's obviously, if we're thinking, okay, we need to put people on estrogen for this, what traditionally people have said, well, the lowest dose possible for the shortest amount of time. Are we now looking at that differently? What kind of dose of estrogen do we actually need, and how long could you stay on it for?
Yes. Well, first, the needle about the role of estrogen has fortunately sort of come back to neutral after being pegged in the far negative zone after the Women's Health Initiative. And the most recent position statement from the Menopause Society here in the U.S. Changed that metric from the lowest dose for the shortest possible time to suggest that we should use the most appropriate dose for the appropriate length of time. For the prevention of bone loss during the phase of rapid bone loss, higher doses of estrogen are needed. And so for oral estradiol, 1 milligram is the dose that in almost all women is effective. For transdermal estradiol, 0.1 milligram is the dose that's required. Smaller doses are effective, but not as effective, and a larger proportion of women on the smaller doses will experience bone loss. After that rapid phase of bone loss, as women are in their late 50s or 60s, then the dose of estrogen can be reduced by half often for maintenance beyond that. So, and the very few women who are given the doses that I mentioned, 1 milligram of oral estradiol, 1/10 of a milligram of transdermal estradiol, very few women experience bone loss on those doses. So other than monitoring bone density every couple of years, there aren't any other good ways to monitor therapy. Measuring serum estradiol levels are not helpful. Some osteoporosis people consider measuring bone turnover markers as a marker of things. In groups of women, those markers are very useful. In individual patients, because of the vagaries of the testing, I have found them less helpful.
It's interesting that you mentioned there the testing of the bloods and things like that, because there's a very large push as well at the moment. People tend to worry about whether or not people are absorbing their estrogen, and there's quite a large argument for people say, well, you've got to be regularly testing. But is it sufficient to say, well, if you've got good vasomotor control or something like that, that you can pretty much guarantee that your bones are all right?
No. Well, yes and no. Obviously, if vasomotor symptoms are improved, that means that there is an estrogen effect. But the doses of estrogen that are often effective in reducing symptoms may not be effective in fully protecting bone loss. So again, smaller doses than the ones that I mentioned are frequently very useful for symptom control. But if the objective is to protect the skeleton, at least during those first few years of menopause, higher doses than might be required just for symptom control should be considered.
Yeah. It's a very, very complex one, isn't it? In terms of getting people to sort of understand the difference between the progression of healthy bone to osteopenia and osteoporosis, how does everybody, well, put it this way, everybody goes through menopause. Not everybody ends up with osteoporosis. How do we sort of work out who is the person who is going to go from normal bone to osteopenia to osteoporosis? Some just stop at osteopenia, and that's that. Do we know?
Pretty much, and the range of change that occur in individual women across the menopause, we're actually trying to ferret out from this one data set. Our initial look at that is that virtually everyone experiences bone loss, and there's not a whole lot of difference between the women who lose the least compared to those who lose the most. So it's a uniform effect. And that fits with what we know. The strongest predictor of, I think I've lost you.
No, I can hear you, but yep.
There you go. I'm back. Okay. So, as I was saying, the strongest predictor of who will will have osteoporosis is what their bone density is at the time they reach menopause. So, measuring bone density at the time of menopause, and again, the indications in the UK and the US are slightly different, but for women who have risk factors for abnormal bone health, including a previous fracture, a family history, being thin, uh, measuring bone density at or just before menopause helps us identify women who come to menopause in the lower part of the expected range, and they are the ones who are most apt to develop osteoporosis.
Okay.
We, at least using American data, women who come to menopause with an average bone density, that is a T-score of 0, uh, the average age at which their hip bone density would reach the threshold where we define osteoporosis is about age 82 or 83. So one will have lost 30% of their bone density to get from a T-score of 0 to a T-score of -2.5. If a woman comes to menopause with a T-score of -1, the average age at which she will have osteoporosis is about age 64.
It's a huge difference, isn't it?
Right. And so that just underscores the point we made earlier that waiting until age 65 to assess bone density is too late. And importantly, if we identify women at age 65 with osteoporosis and treat them with a drug like alendronate, there is an increase. First of all, their hip value is at least 30% below the average value in young women, and about 18% below a T-score of -1. And if we give them alendronate, we will increase their bone density by maybe 4%, not anywhere near back to where they would have been had we prevented their bone loss from happening in the first place.
Yeah. So another, which brings me back to estrogen again for a minute, because I guess another out of that is that, okay, I'm let's say I'm 65, I had my last period at 50. Is it too late for estrogen to help me?
It's not too late for estrogen to help the bone, but we don't normally do that for other reasons. The Women's Health Initiative did teach us that uh, waiting for more than 10 years after menopause or beyond 10 years of estrogen deficiency and then starting therapy results in no protection from heart disease and maybe even an increased risk of heart disease. So it's not recommended that estrogen be started in women who have been estrogen deficient for more than 10 years or so. We know that it works for the bone, but the overall risk benefit profile is not favorable in that situation.
Yeah. In terms of then people staying on it, can I think there was a study that came out quite recently from Anis Mukherjee and Susan Davis in Australia, basically saying if there are no contraindications that, and there's no reason to come off HRT, that you could continue on for bone health. Do we agree?
Exactly. So staying on therapy beyond age 60 or 65 is a very different situation than starting estrogen at age 65. And so I totally agree with that. There's no limit to the duration of hormone therapy. But if for whatever reason it's decided to discontinue estrogen, then it's really important that the individual receive a bisphosphonate for at least a couple of years, either one dose of zoledronate or low dose alendronate for a couple of years to prevent the rapid loss of all of the benefit. So the effect of estrogen on bone, it does not persist. And within a year or two after stopping therapy, all of the benefit that's accrued over however long women took estrogen can be lost. So those
Such
women,
a shame, isn't it?
well, that's the way drugs work.
Yeah.
So bisphosphonates are sort of the unique outlier about that, and whereby binding to the skeleton, they have a very slow off effect, and that's what, of course, we can take advantage of in the maintenance phase of things. So If women stop estrogen, then they need to uh, have, again, a short course of bisphosphonate to sort of consolidate the gains, and then they are transitioned into the maintenance phase protocol that I've outlined.
Yeah. You mentioned smoking and alcohol there, and I think that these are things that people probably don't pay an awful lot of attention to. So let me start with alcohol, because I think that the other thing, when you say you're not supposed to have more than 3 units of alcohol a day, and people think, oh, 3 units, that's a huge amount. That must be 3 glasses. But it's actually one quite full glass. And I could imagine that quite a lot of people would have 1 glass of wine a day, which actually puts them up to something like 32 units a week without even noticing. So
Right.
what is it that alcohol does to bones? And how much of your bone do you lose if you're drinking, say, a glass of alcohol a day?
Yeah, alcohol probably has very little effect on bone density.
Oh,
Uh,
thank
it, it it has an effect on fracture risk, and we don't exactly understand how that happens, other than, of course, people who are highly intoxicated. You can imagine that situation, but so the exact pathophysiology isn't known. Smoking is different. Women who smoke, that there is an increase in the metabolism, the breakdown of estrogen. So women who smoke have lower estrogen levels, and they do experience bone loss. Uh, and it may uh, be as much as zero point 0.4 or zero point 0.5 T-score units,
you.
which is 5 or 6% of a difference from average bone density. So it can make a sizable difference.
Wow, yeah, that's actually really quite scary, isn't it? We had a question over here on the Instagram a little while ago, with a very, very poor connection, unfortunately, which I apologize for, about the amount of calcium you need. Is it sufficient to have it in your diet? Do you need a supplement? Do most people get enough?
Well, there's very little evidence that a daily intake of more than 1,000 or 1,200 milligrams has any added benefit. So that's the target, 1,200 milligrams. If you get it in your diet, that's sufficient, and you don't need additional supplements. In our clinic, we give everybody credit for 300 milligrams of calcium a day in a dairy-free diet. So people who avoid dairy products entirely, then we give them another 1,000 milligrams of calcium a day, 800 to 1,000 milligrams in the form of supplements of calcium carbonate. Or if they have 2 or 3 servings of dairy products a day, then they don't need the additional supplements.
Oh,
But
okay, so
certainly higher doses
breakfast,
are not helpful.
coffee.
Yeah.
Yeah. Okay. Yeah, because it's an interesting one, that one, isn't it?
Yeah.
Whether or not you get enough. And just let me come back to the exercise for a minute, because the other thing too at the moment we have a lot of is you've got to have a weighted vest. You have to be doing your resistance training. If we are doing those sorts of things when we enter menopause, I know you mentioned it before, but I'm just going to torture you out of you again. How much are we saving of our bone? How much are we preserving?
Very little.
Oh.
So again, the SWAN study provided us with some information, and I'll explain to you how sometimes the information or the interpretation of research data can be misleading. So in the SWAN study, as they followed women across menopause, the average loss over a 10-year interval, from 5 years before menopause until 5 years after, was a little more than 10% loss of bone density in the spine. They then divided women into those who were heavy exercisers and those who were not exercisers, and showed that the women who were heavy exercisers only lost, I've forgotten the exact number, but like 11% of their bone density, while the women who didn't exercise at all lost 13%.
Okay.
Those numbers were different.
With osteopenia, then at least that's a
Right.
good thing. Anything's
So,
better.
right. But the interpretation in the paper was that vigorous exercise prevented bone loss. Well, it did prevent a little bit of bone loss, but it didn't prevent the big bone loss that happened over that time. So no study has shown that vigorous exercise, weight loading, resistance exercise can prevent the rapid bone loss that's associated with acute estrogen deficiency.
Yeah, it's a well,
It would be great if that were true. I mean, we all wish it were true. So, in Portland, of course, is the home of Nike, and everybody thinks that running is a part of the city spirit. But women think that if they run enough and eat enough calcium and are nice to their parents and their kids, that bone loss shouldn't happen. But unfortunately, that's not true.
yeah. The oh, I had a thought. Oh, T scores versus Z scores. This is the other thing I was going to ask you about as well. So we have your T score, which is where they compare us to a 30-year-old apparently,
Right.
and Z score when you get compared to somebody of your own age. Is there any use in a Z score at all if all of us are estrogen deficient and osteoporotic?
Not in adults. In kids who are growing, that's crucial, and that's the way we interpret bone density. I know that the Bone Density Society recommends that we use Z scores in premenopausal women. The background of that is that the diagnosis of osteoporosis based on T scores provided to us by the World Health Organization back in 1994 was for postmenopausal women. And the Bone Density Society was very paternalistic and wanted to ensure that premenopausal women weren't incorrectly diagnosed as having osteoporosis based upon a low T score. So they suggested that Z scores be used. In an otherwise healthy individual, T scores and Z scores are the same. And so, but in terms of fracture prediction or predicting who's going to have low bone density, T scores are the more useful metric.
And question over here, I arrived late at this fascinating talk. Have you already covered T scores and the target estrogen levels?
Uh, well, uh, we know that uh, with regard to T scores, the lower the T score, the greater the increase in fracture risk. And it seems like having a T score of -1.5 or better it keeps people at quite low fracture risk. Um, and so that if one is having a target that you want to protect people to not lose beyond that, a T score of -1.5, I think, would be a reasonable target. We
Yeah.
talked about estrogen levels. There's no good study suggesting that measuring serum estrogen is helpful in identifying the appropriate dose of estrogen to prevent or to protect bone loss. And again, it's different in early menopause, where higher doses, higher levels of estrogen are required to protect women from the rapid bone loss that's happening, as opposed to the studies where quite low dose estrogen is effective in elderly women to help them maintain their bone density.
Yeah. Yeah. So in terms of take home messages, what is it that you, oh, actually, before I actually ask that, would you like to see in an ideal world, would you like to see, every woman around 50 have a DEXA?
I think as women approach menopause, having a DEXA test would be ideal, and the indications for DEXA testing in the UK and the US that were first put into place in the 1990s were done when DEXA was very expensive, and the drugs that we had to intervene at the time were also very expensive. Both of those are not true anymore. So in the US, a DEXA test uh, 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 cost $48 or something like that.
Oh, that cheap.
Right. And
Very cheap.
so from an economic standpoint, one can either use that osteoporosis self-assessment tool or use low body weight as an indication, a strong indication for assessing bone density around the time of menopause. Uh, it, it, uh, um, but yes, so having bone density measured at the time of menopause, identifying women who have a T-score of -1 or lower, and considering, unless there's some specific contraindication, strategies to intervene to protect them from that rapid phase of bone loss, that unique opportunity that we have to protect not only bone density, but to protect the structure and the strength of the skeleton. If bisphosphonates were used instead of estrogen, for example, women could receive perhaps 2 doses of zoledronate, one at the time of menopause, another 2 years later, and that strategy alone would protect them from the rapid phase of bone loss, and then they could be in the maintenance phase with very infrequent bisphosphonate therapy for the remainder of their life, and we could make osteoporosis not happen.
Yeah, wouldn't that be amazing? Because I don't think people realize, the risk of death after having a hip fracture, the loss of independence, all until it sort of happens to you. They're really life-changing events. I will stop torturing you in a second. There's a question here about, you mentioned we needed like 1 milligram of transdermal estrogen, and there's a question here over about serum levels. So if you were testing blood, what sort of serum level would you be looking for?
Oh, probably a serum level of more than 40 picograms per mil of estradiol.
And in terms of, we normally work in the hundreds here. What does that what does that translate to in English terms?
I don't know.
I'll have
I'd
to,
have to go back and look in terms of nanomoles.
yeah, nanomoles.
I'd have to go look that up.
Yeah, yes, we need one standardized thing across
I
both.
know. Well, thanks to Americans, we don't have that.
Yes, I mean, well, you could always come to the UK. Apparently they're going to try and in this current environment, there's going to be a push to attract scientists to
I'm very attracted by that idea.
Yes, I can imagine. All right, if you had the final take-home message for you, Mike, what's your message to women? What should they be doing? And to
that
doctors?
that again, that as women approach menopause, we need to pay attention to bone health. That we have a special and a unique opportunity. We have very effective ways of identifying individuals who are most likely to develop osteoporosis. We have very safe and effective ways of preventing bone loss from happening. And with the concept of maintenance therapy, uh, embodied again in the study by Dr. Boland and the group from New Zealand, published in January, where giving very intermittent bisphosphonate therapy maintains bone density indefinitely. We have a very inexpensive, safe strategy for lifelong management and protection from developing osteoporosis.
And that would be a miracle thing. Thank you so very, very much, especially given the state of your poor throat. I feel really horrible for torturing you for literally 48 minutes. So look, thank you again, and hopefully we shall hear from you again sometime in the future.
Fiona, I would look forward to that. Thank you very much.
Thank you.
Bye-bye.